Hello guys, this is Miss Hill, and we are going to discuss in this lecture video individual module 10.2, specifically related to ADHD, autism, cerebral palsy, and failure to thrive. And you will find all of these under the concept of development. Here are your learning outcomes for all 4 of these disorders. And we're going to start with ADHD. So, attention deficit hyperactivity disorder used to be thought of as just a childhood condition. But research now shows that it persists into adulthood for people diagnosed with this disorder, with at least 30 to 70% of individuals who are diagnosed into childhood. So, in essence, we have found that it's not only just a childhood illness, but it also extends into adulthood. These people have difficulty completing tasks. They are hyperactive. They also have hyperkinesis, which are excessive movements, so they can't be still. And oftentimes they're impulsive. The pathophysiology for ADHD is really very unclear, but we do have some clues as to where we think it comes from, or as to what causes it. And typically they have to do with brain characteristics. So first, there's a theory that there's some type of neurotransmitter deficit, specifically with dopamine or norepinephrine or both. There's also a decreased self-regulation of the brain, and what happens here is the brain just doesn't mature as it should normally. And then this self-regulation piece that the brain is normally capable of, the person with ADHD is not able to self-regulate like a normal person because their brain doesn't mature in the same way. Oftentimes, ADHD is diagnosed before the age of 7, and like I said, it will continue into adult life in at least 30 to 70% of the cases, which is a pretty big range. It's a multifactorial illness in the sense that several different things contribute, or the theory is that several different things contribute. And here you see some listed: genetic, biologic, environmental, TV exposure, and prenatal issues. And sometimes it's not just one of these, but maybe a combination. So in terms of genetics, at least 41% of adults who have ADHD will end up having children who have this disorder as well. So there has not been a specific gene that has been actually linked to this disorder, but the theory is that there is some genetics behind it just because of those staggering statistics. There may be environmental reasons. One of those theories is lead exposure. TV exposure also tends to contribute. So if a child watches TV daily from the time they're at least 1 to 3 years old, it's been associated with attentional problems by the time they hit age 7. And we know this through research. In terms of prenatal issues, we know that exposure to alcohol or tobacco smoke, preterm labor, or placental problems that cause hypoxic events can also be linked with ADHD. And even on top of these things, family stress, poverty, poor nutrition can also contribute as well. So here's a little chart, and this is just a chart to sort of let you know how people with ADHD may feel. They oftentimes feel misunderstood, they feel subordinate, they're ashamed because they can't control some of the issues that they have, like the impulsive behavior or the excessive movements. They're afraid to fail, and they have a desire to be loved and accepted for who they are, just like all of us do, but they often have difficulty with social interactions because of some of the characteristics that this disorder causes them to have. So in terms of assessment data, there are several behavioral clinical manifestations that you'll find in children who have ADHD. They have a great inability to focus on tasks. They just cannot allow themselves to stay focused. They are fidgety, which is that hyperkinesis we talked about in the first slide. They oftentimes have sleep disorders. They have difficulty falling to sleep. They have difficulty staying asleep. They're highly anxious. And they have an impairment of social, academic, and occupational functionings. Occupational, we're talking about into adulthood, and some academic. And a lot of the times they also have mood disorders. In terms of academia, ADHD people often do poor in an academic setting, but that's not due to the fact that they have a low IQ, as some people stereotype. It has to do with their inability to actually be able to focus on the task at hand. Many times, most of these individuals are actually very intelligent. They just can't focus enough to complete the tasks that are needed to be completed in order to make good grades. Girls are actually diagnosed much later, typically, than boys are. It's not caught quite as early. Girls tend to have less aggression and less impulsiveness than boys do. But they are more anxious, they have greater mood swings, they have more social withdrawal and rejection, and they tend to have more cognitive and language problems when compared with boys. So for nursing diagnoses, what might you see in a child with ADHD? Well, a risk for injury related to their hyperactivity. So think about that hyperkinesis, the fact that they just can't stay still. They have to continue movement just constantly because that's what this disorder causes for them. So they're at a risk for injury. Impaired social interaction related to impulsivity and aggressive behavior. If you're impulsive and you have aggressive behavior, it makes it very difficult to make friends, especially when you're young and you're in school. So they have this impaired social interaction with other human beings and with other peers their age. So they tend to have a difficult time making friends. They have altered nutrition related to their hyperactivity. They can't be still, so they don't want to really eat. So oftentimes they may have delayed growth. And then again with the disturbed sleep pattern related to the disorder, because they're just not able to go to sleep or stay asleep. So what are some nursing interventions in relation to ADHD? Well, here are 4 listed for you. We have pharmacologic therapy that we can initiate. There's environmental therapy and support, behavioral therapy, and of course, as always, we always support the family and the individual. In relation to medication therapy, there are 3 types of medications you find that we administer to people with ADHD. We administer psychostimulants, non-stimulants, and then there are psychostimulant. There is a psychostimulant skin patch, actually, that's pretty new. In terms of the first type, which are psychostimulants, those would be your medications like Adderall, Ritalin, and Concerta is a fairly new one. And then there are some non-stimulants, which is your second type, like Strattera. Strattera was originally developed for depression and was actually proven not to do a very good job for that, and was found that it actually controlled some of the characteristics related to ADHD. So it's now approved for that, and it's why we see it used in children with this disorder. But the big thing with Strattera, especially teaching-wise, is that we have to let parents know that one of the side effects of this medication is suicidal ideation. And that's very important for a parent to understand if they have a child who's taking this drug. The skin patch, the psychostimulant skin patch, that's fairly new. The name of that one is Daytrana. And all three of these types of medications actually block the reuptake of selective dopamine and or norepinephrine. It might block the reuptake of both of those, or it might block the reuptake of just one or the other. But the important thing to know there is that if we're blocking the reuptake of those neurotransmitters, then what we're doing is we're increasing more of that neurotransmitter in the brain. And as you remember from the beginning of this PowerPoint, often that's a theory, is that people with this disorder don't have enough of those two neurotransmitters. In terms of environmental therapy and support, we want to decrease stimulation for these people. We want to maintain an orderly and a clutter-free environment. We want to impose consistent limits. They need to be put in small classrooms in terms of school, and they need pretty close supervision. When it comes to behavioral therapy, it's very important to reward the appropriate behaviors for these children and provide consequences for undesirable behaviors. And that has to be done in a timely manner, almost immediately. It's important to establish cues for when their behaviors are starting to escalate. So if parents can establish some sort of specific cue and have that particular cue, have their child know that that particular cue means you're getting out of hand, or you can't be still and it's starting to get worse, and then they can implement that cue whenever they observe that behavior. It helps trigger the child to be able to sort of slow down and attempt to self-regulate that behavior. But most importantly, in terms of behavioral therapy, it's very important to have all family and teachers and adults that are very close in the child's life on board with this type of therapy, because it has to be consistent across the board. So intervention-wise, in terms of nursing, what can you do? Well, environmental control is important. So if you have a child who's in the hospital who's diagnosed with ADHD, it's very important to try to control their environment as much as possible. Don't put them in a room that has another child in it. Try to keep them in a room by themselves. Try to, it may be very important to try to put them in a room that's away from noise if you can. We want to focus on low stimulation, because the more they're stimulated, the more difficult of a time they have focusing and completing whatever task at hand is needed. They do need close supervision, so their care needs to be individualized. They may, if they're extremely bad, they may need to be a one-on-one patient depending on what's going on. They need a structured daily routine. They need to know what to expect. They need frequent reminders, and those can be written or verbal depending on how old your child is. They need short, simple, and slow directions. It does not help to give them a long list of things to do that you expect from them. It's much easier for these children if you break it down into small parts, and it's short and it's simple. We have to reward and punish their behavior as soon as possible. Provide emotional support for the parents, and then educate parents about any types of drugs that they may be put on and how to minimize the side effects of those. With the psychostimulants, oftentimes these children will lose their appetite, and so that's another very important thing to teach parents, is that they may not want to eat and they may start to lose a lot of weight. So what do we expect? We really want these children to be able to demonstrate an ability to focus and complete the task at hand that they've been given to do. We want them to be safe. We don't want them to have physical injury or inflict injury on others because of their impulsivity or their aggressive behavior. We also want to make sure that the caregiver can safely manage their medications. Many of these drugs, almost all of them, that children with ADHD are prescribed are Schedule II drugs. So they have to know how to safely manage them. And we want the child to be able to form meaningful social relationships, especially at school. That's a very big piece of development for children, is being able to develop peer relationships. And if they can't do that, it affects them later on in life. So there are some screening tests that we can do for ADHD. It's always important to get a good history, just like with any patient. And you may have to collect this history from data that comes from home, from school, or from daycare. They will end up with a physical examination to rule out any other neurological problems. So we want to be for certain that their behavioral characteristics are not related to an underlying illness that may be missed before we just diagnose somebody with ADHD. And there are certain specific screening tests and tools that can be used, just to name a few. The Vanderbilt Parent and Teacher Scales, there's a Disruptive Behavior Disorder Scale, and there's an ADHD rating scale, and those are not all, that's just a few. So autism. Moving on into this disorder. Autism is characteristically demonstrated by an impaired communication and social interaction pattern. And there's also usually a presence of repetitive and restrictive behaviors from these individuals. And characteristics of people who have a diagnosis of autism can range anywhere from mild to very severe. Oftentimes, autism becomes apparent by the time somebody is 3 years old, and you can note these specific behaviors. But we're getting better and better at recognizing this a little earlier. So a lot of the times now we can discover this in their first year. Oftentimes, the way we actually start to wonder if someone is autistic is because they have delayed speech. But in general, autism is characterized by an impaired social interaction and communication with others. We see those repetitive, stereotype behaviors. They oftentimes have a very labile mood. Nothing really bothers them one way or the other. Or either they are set off by absolutely nothing, and things that should affect them just don't. They have an impaired ability to adapt to new situations. And they also have an impairment in their attention span and their ability to organize the types of responses that they have in relation to certain situations they're put in. So we don't really know why autism occurs, but we believe that it is associated with some complex interactions that happen between their genetics, their immunologic, and their environmental factors. It also has been linked to different types of prenatal exposures, like fetal alcohol syndrome. So moms who drink alcohol. Maternal age also has been linked with autism. So moms who are greater than 40 years old and dads who are greater than 50 years old, their children are at a greater risk for autism. Moms who've been exposed to different types of teratogens, children with PKU, Fragile X, and Down syndrome are also at a greater risk to have autism. And oftentimes, people with autism have some type of cortical malfunction, and the current research is looking into the role of neurotransmitters like serotonin and dopamine in their relation to autism patients, because it has been found that there is some type of abnormality with these neurotransmitters in patients who have been diagnosed with this disorder. It is important to note here, however, that there has been absolutely no link or proven research studies to suggest that mercury in vaccines contribute to autism. So here is a little chart for you about the signs of autism and then the reality of autism. And I thought this was very neat and explained things in a really simplistic manner. So as the nurse, what might be some things that you could see in a patient that presented that would clue you in to the fact that they may have this disorder? They have an inappropriate playing with toys. They may sort them at an age that is inappropriate to be sorting. They have an inability to relate to others, so they have that impaired social interaction. They may be hyperactive, or they may be very passive. They have inappropriate laughing or crying. They're oversensitive or undersensitive to sound. They have poor speech or lack of speech. And a lot of times, in terms of speech, you will see children with autism have something that's called echolalia, and that's a compulsive parroting of a word or a phrase that's spoken by someone else. So they'll hear somebody say something, and then they'll repeat it back over and over again. They oftentimes have a strange attachment to objects. And it may not be something like a blanket or a bear like most other children, but it might be something like this boy's holding, like a leaf. They have a very hard time dealing with changes to their routine. They need severe consistency. And they also have a lack of awareness of danger. As an infant, autistic children do not like to be cuddled. They don't like to be touched often. They tend to not like loud noises. And like I said, they need a great deal of consistency. So how do things appear from the autistic child side in relation to these signs that we just talked about. So they play with toys in ways that just don't make sense to other people. It makes sense to them, but just not to people from the outside looking in. They find other kids less interesting than the rest of the things around them, so that leads to that impaired social interaction. They have unexpected energy levels. You don't know what to expect from them. And they have good hearing, or either they really just like to listen. They find different kinds of things delightful or frustrating than maybe normal children. They tend to be very less interested in talking to people than they would like. And if you don't talk to people, you don't develop speech very well. And in terms of consistency and dealing with change, they really just want the world to make sense to them. And it's hard to get the world to make sense if your brain cannot comprehend what's supposed to come next. And in terms of having a lack of awareness for danger, it has a lot more to do with the fact that they pay attention to other types of things in their surrounding that interest them, so they miss those signs of danger. So there are several things that may trigger episodes for children with autism. Things may be going too fast. Things may sound too high. Things are too overwhelming. They're too unfamiliar, too loud, too hectic, too close. They might be too bright, too unexpected, too vague. Might be too loose or too tight, or it might be too new. And these are just a really simple way of explaining how to remember as a care provider what types of things overstimulate children with autism and maybe send them in to some behavior that we don't want to see. So in terms of assessment and diagnostic testing, well, we have behavioral indicators, and to be able to diagnose someone with autism, you have to have the presence of a certain set of specific criteria. And this PowerPoint has the DSM-4 on it, but there is actually a DSM-5 now that includes these different specific sets of criteria that have to be met to diagnose a child with autism. These children will have a CT, an MRI, an EEG. They may have DNA testing, and they may have a lead screening to rule out some type of environmental factor. There will be a history taken that includes their birth and their prenatal history. They'll have a growth and developmental screening. And then we always want to rule out hearing and visual loss, because in order to diagnose someone with autism, we want to make sure that we have ruled out all other causes that could be causing the child's behavior or their symptoms or their characteristics. There are some specific screening tests. There are several that link with autism and the diagnosis of that disorder. A couple of them that are fairly popular are the CHAT and the MCHAT, so CHAT, and that's the checklist for autism in toddlers. And then the MCHAT is the modified checklist for autism in toddlers. There's also an autism diagnostic interview tool. There's a childhood autism rating scale, or it's abbreviated as CARS. And there are several others, but those may be some that you hear. So for nursing diagnoses, what you may find is that these people have impaired communication related to their brain dysfunction. They have an impaired social interaction related to their lack of responsiveness to other people. They are at a risk for injury because they do not notice their surroundings like a typical child would. They have families that are under a constant caregiver role strain because they're taking care of a child with a disability that can be very taxing at times. They may have delayed growth and development, and they may have altered nutrition or low birth weight related to their behaviors. And it's important to teach parents in terms of the altered nutrition that it actually helps these children if you allow them to perform their rituals or their behaviors before eating. Then they will tend to eat better for you. So in terms of nursing interventions, especially if you have a child in the hospital, what can we do? Well, first and foremost, we want to always keep our patients safe. So we have to provide safe care that meets their essential basic needs. And that might be one-on-one care if possible. If you have someone at the very end of the autism spectrum and they have the severe symptoms, they might be a one-on-one patient. You want to keep your sentences short and clear and direct because we try to decrease that stimulus as much as we can, and we want them to process as much of the information as we're saying. So we have to be short, clear, and direct about what we say. We role model communication. Often these children do not communicate well with other people, so we have to role model that so they pick up behaviors. When I was in college, I actually took care of a child who was autistic through an agency. And part of my job was to actually get him to meet certain goals. And one of those goals was to be able to communicate effectively with other people. So what I would do is, he was 5 years old, and what I would do is I would load him up in my car, and I would take him to the mall in Raleigh, and we would just walk through the mall, and I would say hello to people and wave at them. And the goal was to get him to emulate my behavior so that he would learn how to effectively communicate with people. And it did work. I would walk him through the mall, and I would say, Ari, say hello. And he would say, hi. And I would take him to the playground and allow him to interact with other children. So it's important to role model that communication and to encourage it from them. You want to keep your child's routine and rituals intact. Don't try to disrupt those because that will disrupt their whole day. They need consistency. Early screening and early intervention is very important. And oftentimes they need to be referred to speech and language therapy, especially if this is not a disorder that's caught really early. If this is not a disorder that's caught until they're 3 years old, then they have missed a lot of development in terms of speech and language. If we can catch it really early, like in that first slide, before a year old, we can go ahead and get them into therapy so they can start developing those skills. It's important to provide a lot of emotional support to the family. We have to be patient with them, understanding, and we have to be sensitive to what they're going through because these are difficult children to take care of oftentimes, especially if they're at the severe end of the spectrum. We want to encourage membership in support groups and encourage them to get these children immunized because of all of the false research that has been published in the past in relation to mercury-related vaccines. It's important to educate parents that this has all of that research has been debunked. We also may give medications to people with autistic disorder. And just a few of those types of medications may be things like stimulants, SSRIs, or mood stabilizers. So really what we want to see at the end of the day is that the autistic child is able to communicate basic needs to their caregiver. We want them to remain free of injury. We want them to be able to form relationships and friendships with their parents and their peers. And we want the family to be able to adapt to the disorder as a whole, because this is not something they will ever get better from. It's also important that we make one of the goals for these individuals the fact to reduce the rigidity of their routine and some of those repetitive and obsessive machine-like movements that they have, because that helps them to adapt in society better and to increase their social interaction so that it's not quite as impaired. Moving on to failure to thrive. Failure to thrive is a physical and a psychosocial issue for both infants and children. It has a measurable indicator, and that indicator has to do with growth plotting. Weight and possibly height has to be below the 5th percentile, or we have to have falling percentiles on a growth chart in comparison with children of the same age and gender to be able to diagnose failure to thrive. So take a look at this growth chart on the right hand side of your screen here, and you can see this child starts to grow in weight, and then all of a sudden we kind of fall off the charts there a little bit, and then you can see somebody caught it, and we've started applying some interventions, and now we're kind of going back up to where we should be. So this is what you might find on a typical failure to thrive child's growth chart. It's always very important to assess growth charting documentation as a nurse, because that's the best way that you can determine if there is an issue going on with an infant or a child. And that does not just apply for failure to thrive, but it also applies for any child, just a normal healthy child. This is an easy way to catch complications. So we have two categories for failure to thrive. We have an organic category and an inorganic category. In category 1, where we have an organic cause for failure to thrive, that means there is a physical issue of some kind that is causing this child to have those that decrease in weight or that fall on the growth chart. So think about your child who has a cleft lip or a cleft palate, or maybe they have a bowel obstruction. Those things are going to cause them to not be able to absorb nutrients as well, not be able to take in calories as well, and they are going to end up in a state of failure to thrive if we don't correct those issues right away. So that would be a physical cause of this illness. Inorganic causes have to do with psychosocial issues or idiopathic causes. And you may also hear inorganic causes called feeding disorder of infancy or early childhood. And 80% of your failure to thrive cases are inorganic. Sometimes you may have a combination of both the first and the second category. So who is at risk? Children who are at risk, obviously the ones with cleft lips or palates or bowel obstructions, ones with a physical cause, but specifically for the inorganic cause, infants who are at risk are ones that are deprived of mothering, specifically between the ages of 3 to 15 months of age. And the reason for this is that they will not learn to form significant relationships or to trust other people. Also, they may have caretakers who suffer from depression, substance abuse, mental retardation, or psychosis. And if these types of people do not respond to an infant's feeding cues, or they don't offer the infant enough food, then typically what happens is that the infant becomes irritable, they're not soothed as easily, and then they may give unclear cues about the fact that they're hungry, or maybe they stop giving cues at all, and then they end up with failure to thrive. So we see several physical signs for children with failure to thrive. First and foremost, we see a falling weight and height on the growth scale. We see a loss of subcutaneous fat, a lack of muscle tone, and a lack of energy. They're very fatigued. They are oftentimes extremely irritable. They may push their caregiver away. So think about that infant who is deprived of mothering, that does not learn to form those significant relationships or that trust that they need to be able to relate to other people. So then you may see these people start to push individuals away physically. They might refuse food, have a disturbed sleep pattern, or a motor development delay. This is a kid who had failure to thrive that actually got better. And the diagnosis for failure to thrive occurs mainly through your assessment data. Lab testing and other types of testing is relatively ineffective to diagnose failure to thrive. Really, what we see diagnostically is that fall on the growth chart in height and weight, or both. So for some nursing diagnoses, definitely imbalanced nutrition related to their inability to ingest or absorb nutrients. They'll have delayed growth and development related to their inadequate food intake. Impaired parenting, possibly, in terms of maybe age, educational level, substance abuse, depression, all those things we talked about. And if these children are not taken care of quickly and they continue to remain in a failure to thrive state for a long period of time, they will often end up with some type of brain injury related to their malnutrition. And fatigue is another nursing diagnosis that you will see with these individuals. So in terms of interventions, our nursing interventions for failure to thrive patients are directed mainly at improving their nutrition. We take serial measurements of their height and their weight, and those have to be documented on the growth chart so we can assess where we've been and where we're going. Nutritional assessments are important, so keeping up with intake and output, vital signs, laboratory testing. If you think about the child who's not getting enough nutrition, then we want to check blood counts. We'd want to know what protein is. We want to know what their electrolytes are. So laboratory testing in terms of making sure they don't have other types of deficits related to their failure to thrive, not to actually diagnose the failure to thrive. We need to role model parenting and nurturing behaviors and skills. We may need to refer parents to parenting classes. We have to teach correct methods of feeding and assist the physician to rule out organic causes. If there is an organic cause for failure to thrive, you might have to prepare the family or the patient for surgery. For example, to repair the cleft lip or a palate, or to alleviate a bowel obstruction. And oftentimes there is no medication needed for this disorder. We only identify the cause, and then we resolve the issue of whatever we find the cause is. So what we expect over anything is that the infant will gain weight and grow. We want the infant to demonstrate motor development progress. We want the parents to demonstrate positive bonding and parenting skills. And we want the infant to display an interest in play. All right, last one of the developmental disorders that we're going to talk about today, and that one is cerebral palsy. Cerebral palsy is a non-progressive impairment of motor function control, and it includes movement, coordination, and posture. And this is another disorder that can range anywhere from mild all the way to severe. It can include sensory perception issues like visual or hearing difficulties. It can also include paralysis in some cases. It may or may not include mental retardation. And oftentimes, cerebral palsy is due to the result of some type of insult to the developing brain of the fetus, the neonate, or the infant. And that can occur either in the later stages of pregnancy, that insult can occur during birth, or it can occur within the first 2 years after birth. So there's a wide range of times that someone can be exposed to an insult that will actually cause this disorder. And it occurs in approximately every 1 out of 308 live births. There are 4 types of cerebral palsy. There is spastic, dyskinetic, athetoid, ataxic, and mixed. The spastic type of cerebral palsy, or CP, as you may hear it called, are tense, tight, rigid muscle movements. These people with the spastic type have a persistent hypertonia. These are the ones that you see that have contractures. The second type, the dyskinetic and athetoid, they have uncontrolled writhing movements of all of their 4 extremities. For the ataxic type, these people have hyper or hypotonia. They have an unstable gait, poor balance of their trunk and their limbs. And then you can have a mixed type in which you see really no dominant motor pattern as compared with the other types. And they have unique compensatory movements and posture that helps them maintain control over whatever type of neuromotor deficit they might have. So they have a combination of characteristics from the other types of CP. So here's another slide to sort of explain the different types of CP. The spastic type is the most common type of cerebral palsy that you're going to see. That's over 80% of the cases that you'll come in contact with are of the spastic type. These people often have to have physical therapy. They might be on muscle relaxants. You'll see that they have braces, splints, or other types of orthotic devices. And they may have to have surgery actually to loosen the contractures that they have because of the hypertonia that they experience with this type of CP. People with a spastic type of CP have some type of injury to their pyramidal tract or their cerebral cortex. For the dyskinetic or the athetoid cerebral palsy, these people you may find have exaggerated posturing. They may have tremors along with those constant and uncontrolled movements of their limbs. And oftentimes it includes their head and their eyes too. These types of patients have had some sort of insult to their basal ganglia part of the brain or their extrapyramidal tract. In terms of the ataxic classification of cerebral palsy, you'll find these people are the ones that can use canes, crutches, walkers, or they may have other types of orthotics that help them to walk or to promote mobility. These individuals typically tend to exhibit hypotonia in infancy, so the babies that have no tone, and they have a really wide-based and unsteady gait in most cases. And these people have had some sort of insult to their cerebellum or the extrapyramidal tract as well. So what we find is that with CP, there is some type of damage to the motor areas of the central nervous system. We just discussed some of those, and depending on the type or the classification of CP you have, will depend on what area of the brain actually received the insult. And so how do we receive the insult? Well, it can be congenital, but a lot of the times it has to do with something that maybe happened in labor or happened during birth. Could have been something that happened during pregnancy that provided some sort of hypoxic or ischemic event. It could be due to infection, like chorioamnionitis during pregnancy. And if it happens after the baby is born, it can be contributed to things like shaken baby syndrome, some sort of insult to the brain. I posted up this little picture here because I thought it was pretty neat, and it gives you a really quick rundown of cerebral palsy and all of the different things that go along with cerebral palsy. So it talks about the prognosis, how we manage it, different symptoms you see, the types, gives you a definition, the etiology, pathology, epidemiology, who's at a greater risk. You can see there premature babies, twins, or multiples, their age. It tells you about ways that we can help prevent cerebral palsy. So take a look over that. I thought it was a pretty good little picture. As a nurse or a physician, how do we suspect if someone has cerebral palsy? Well, we can catch it early if we are aware that some of these signs and symptoms are actually related to CP. So you can see this baby in the picture here has hypotonia, or that decreased muscle tone. When you pull the arms up for that infant, his head goes all the way back. He doesn't attempt to raise his head. And then when you hold him on his belly, he just kind of hangs there like a limp noodle. He does not try to, he doesn't have a reflex to try to protect himself. So oftentimes these babies have no head control at 3 months. They don't smile. They're unable to sit up by the time they're 8 months old. They have stiff arms or legs. They might have a persistent tonic neck reflex after 6 months, which is when it's supposed to disappear. They might have a floppy or a limp body. They may choke during feeding or have excessive drooling because they don't have the reflex that they need, that's like a protective gag reflex. They may have an asymmetrical crawling pattern, so they may crawl with either 2 or 3 of their limbs instead of with all 4 of them. Oftentimes your physician is going to order some type of CT, MRI, or maybe a PET scan to confirm that there's been some type of neurologic injury if you find these signs and symptoms. And it's also possible to do a cranial ultrasound. Nursing wise, there are two pretty simple screening assessments that you can do that will clue you into the fact that a kid may have CP. So for a baby who is between 6 and 12 months old, you can actually put a clean diaper over their face. And if they are a normal infant, they will use 2 hands to try to take that diaper off of their face. But a kid who has CP will only use 1 hand, or they won't try to remove the diaper at all. And then there's another screening assessment in which you can turn their head to one side, and a persistent asymmetric tonic neck reflex, like we said earlier in this slide, would indicate a problem. So we suspect CP in any infant who has persistent primitive reflexes that should have disappeared. Nursing diagnosis wise, what you're going to find is impaired mobility related to their lack of control or their muscle tone, a delayed growth and development, impaired verbal communication. They have risk for aspiration, risk for impaired skin integrity, and caregiver role strain. These children are a big challenge to take care of, especially if they're on the severe end of the spectrum, because oftentimes they cannot do much for themselves at all and have to be cared for. In terms of interventions that you would provide as a nurse, we have to make sure that we keep their airway patent at all times. If they do not have protective reflexes, then they're at that great risk for aspiration, and we have to make sure that we protect that airway. We want to ensure that they have adequate nutrition. We want to maintain their skin integrity. If they're unable to get themselves to the bathroom, then that means that no matter how old they are, we're having to provide that basic ADL for them. So we have to remember that they may need to be checked and changed often. We want to promote physical mobility, especially if they're a CP patient who's on the mild end of the spectrum who can walk with braces or crutches or a walker. We want to promote that physical mobility. We want these people to be in physical therapy. Even if they're on the severe end of the spectrum, they need to be in physical therapy because we don't want them to develop contractures like in the spastic type, or we want to lessen the chance that their contractures become worse. We want to promote growth and development, refer them to a speech or an audio therapist if they're able to talk, promote independence, but we have to think of their safety first. And we want to provide family support and counseling and educate the family about different types of medications they may be on, their effects on their oral health, and seizure thresholds. So what do we expect? First and foremost, we expect that their airways will stay open and that they will not aspirate. We want them to have adequate nutritional intake based on their energy needs. We want them to have intact skin and not develop any breakdown. We want to make sure they don't develop contractures or deformities if we can prevent those, or to make sure that they do not get worse. We want them to be able to adapt to use different types of assistive devices so that they can create meaningful relationships with other people. And assistive devices can include devices for mobility or communication. Oftentimes, cerebral palsy patients may not be able to communicate verbally, but it does not mean that their intelligence is not there, so they can communicate with a computer. The family will identify respite and support services. Oftentimes, these families who take care of these children have to take care of them all the way into adulthood, because although this illness is non-progressive, it never gets better either. So these families oftentimes need respite time, and they need support services to help them so they can get some rest. And that is it for IM 10.2 under your module of development. Thanks for watching.